Good morning and thank you for being with us. This is Khalil Hachem with US Arab Radio. Happy holidays. We appreciate your taking the time to be with us. Today we have a special program for you. We are talking with Dr. Nicholas Shamma, a world-renowned fertility specialist. Good morning, Dr. Shamma. Thank you so much for being with us.
Good morning to you and to all our beautiful listeners across the US or wherever they're listening to us.
Thank you so much. We haven't talked to you for a while. What we're going to do quickly is to remind our listeners to become familiar with you. Just tell us a little bit about you, what you do, the different locations that you have, and it'll give us a good refresher.
Well, I am a fertility subspecialist. I have done my training in obstetrics and gynecology from Yale New Haven Hospitals, Yale University, and then did also my subspecialty training in infertility and reproductive endocrinology at Yale University, and have been in practice literally 30 years as of this year. And currently I'm the president and executive officer of IVF Michigan Fertility Centers and IVF Ohio Fertility Centers, and also of the Gift of Life Surrogacy Agency, which is our sister company that we have in Ohio. And we have offices all across the state of Michigan and northern Ohio, ranging from northern Michigan and in Petoskey and Charlevoix to Saginaw to Macomb to Grand Blanc to our main center is in Bloomfield Hills, Michigan. And we also have another one in East Lansing. We have a center in Ann Arbor, Michigan. We also have one of course, in Dearborn for our, listeners who are of Arab or American descent. And also we have one in northern Ohio, in Sylvania, Ohio. So, and we're opening as of 2023, God willing, we're opening a center. So it's going to open in May of 2023 in Grand Rapids. And it's going to be a major center similar to the one that we have in Bloomfield Hills.
Wonderful. That's a great success. The main one in Bloomfield is on Woodward, isn't it?
It is on Woodward. It's on the southeast corner of Woodward and Big Beaver.
Yeah. Was it fertility that's all you wanted to do from the beginning, or this is something that you kind of morphed into?
No, actually, I'm subspecialty trained in that field. So yeah, fertility is what I wanted to do. And actually, I was brought to Michigan to help develop assisted reproduction in the area for our field, because remember that, the whole story about assisted reproduction in vitro fertilization didn't start into being till the late 80s in the United States, and worldwide, nothing was there since 1978. So that's when the first baby worldwide was born in London, in England. So, and she, currently now is, almost 44 years old.
A grown woman now.
She's definitely a woman.
Yeah, with children of her own, I hope.
I'm not exactly sure if she has kids or she doesn't have kids. But to tell you a story, this year was the first year that I've actually done an IVF procedure on somebody that I actually helped create from an embryo. And so her mom was a patient of mine, did IVF back in 1993. And she came last year, and the young daughter who was the product of that IVF procedure needed IVF herself, and she's in Michigan. She lives in Saginaw, Michigan, and currently she is very pregnant and due to deliver very soon. So that for me is my first.
Yeah, double success.
Yeah, I don't know what you want to call it, but certainly it's a milestone.
Absolutely. What is it about IVF that really when you talk about it, like your face lights up, and it's you have a passion for helping people who really need help in that regard?
I'll tell you, it's one of those fields in medicine that is very rewarding. It's rewarding in many senses. It's scientifically challenging, scientifically interesting, to put it mildly, but also it involves taking care of young women and young men that are striving to have a family. And in my opinion, there is nothing more beautiful than creating or, more babies and offspring and so on. So for me, it has been a passion of mine since the beginning. And the fact that you could see a major relief and a major satisfaction in the faces and in the behavior of patients that come in before suffering from infertility and after they become pregnant, and especially after they deliver, is insurmountable to a significant degree. So, I mean, it's that satisfaction that I see in the faces of my patients that gives me all the joy in what I do every single day. So,
yeah. What's the biggest challenge in what you do?
The challenge, there are many challenges. I mean, some of the challenges has to do with the fact that the procedure itself is demanding. It's demanding in terms of the patients and demanding from us to actually help create the setup so that it becomes successful. And I think the most interesting and yet humbling part of the story is that it doesn't always work. I mean, thank God, at least in very, very good programs in our hands, I would say 95% of patients that come to us, Khalil, eventually end up with a baby. And I say eventually because it might not happen from the first time, but eventually they go home with a child, and that's where we get the satisfaction and the wonderful things that happen as a result of that. But then there is the few percentage of patients that cannot be helped, or we are unable to help them. And in my opinion, that creates a very big emotional challenge on our end. And it's burdensome. Let me put it in perspective. When I did my training at Yale many years ago, 30 years ago, as I mentioned earlier, the success rate of an in vitro fertilization procedure was around 18%. So I would talk to 5 couples to maybe one of them eventually from one procedure for that person to go home with a kid. Currently, if we do genetics on embryos, and we can talk about that in a little bit, 76% of the time, a patient can end up going home with a baby from a single embryo transferred in a single procedure. So that is a dramatic difference, and therefore we don't have to be in that situation where I have to be telling the couple or the patient and their husband or her partner that, it failed, and then we have to find out why it failed and so on. So that is a major relief that I only have to do it maybe 1 out of every 5 patients. As of 30 years ago, I had to do it 4 out of 5 patients in the past. And that's where the science and the technology.
Yeah. What exactly is it technology that's better now? That's how
allowing
you to help
everything. I'll tell you something funny. In the beginning, it was like a Wild West.
Yeah.
IVF, because we didn't really know. We didn't have data on humans. Not a single patient before 1978, before Louise Brown was born, we didn't have any idea how to do it in humans. So since then, and I can tell you that, for instance, at Yale, where I trained, we had the second baby born in the United States from IVF. So to make a long story short, we didn't know how to do things. We didn't know what conditions need to be in the laboratory. How do we do certain things? And we're talking about human life here. Potential human life. We're talking about not like working in a lab somewhere and doing experiments, because we can't experiment on humans. So to some degree, a lot of things we did or didn't do was by trial and error. And eventually science caught up and allowed us to do studies that are randomized, prospective, so that we can come up with answers to questions that we posited at any point in that process.
It's really great to be able to help individuals who are wanting to have a child and are unable to. And I can't imagine the joy I want to focus on the joy. This is the more positive,
Well, yeah, of course, of course.
than the disappointment for with some of the people who really don't and end up not going home for with a child. So and I'm sure there's some stories that you have, those that you wish you had been able to, but things didn't work out.
Eventually, I'll tell you, I'm going to write a book about all the situations that I had to deal with over the years that are interesting situations. But that I'll do it after I, stop.
You retire.
After I stop. And just to put things in perspective, Khalil, remember that since I think 1987, which is basically when IVF became developed in the United States to some degree, where we can offer it to people. There's more than 1 million babies born in the United States from in vitro fertilization. And if you think of in Southern Europe, for instance, and in Europe in general, Western Europe, almost 5% of all babies born are because of IVF currently. In the United States, that number is, I think it's somewhere around 1.9%. In Australia, for instance, it's around 4% and so on. But that equates to somewhere around, at least back in 2020, if I remember correctly, it was around 73,000 babies born from IVF. And imagine almost 80% of them are born from embryos that have been cryopreserved from before. So these are not fresh embryos that we're putting back in those patients. And that is a dramatic change and improvement in the way we do things, actually.
Absolutely. What we're going to do is we're going to take a short break. We'll be right back. Please stay tuned.
Sure.
On behalf of the U.S. Arab Radio team, we wish our listeners, followers, and community happy holidays, and we'd like to give you a big thanks for your continuous support.
مراكز IVF للخصوبة وأطفال الأنابيب تستقبل مراجعيها في بلومفيلد هيلز ومراكزها المنتشرة في ميشيغان وأوهايو. فريق من أمهر الأخصائيين في مجال التلقيح الاصطناعي. يعتبر دكتور شما أخصائي الأمراض النسائية والتوليد من أمهر استشاريي الأمراض التناسلية والعقم بخبرة أكثر من 10,000 عملية طفل أنبوب. رعاية طبية ممتازة وتفهم عميق للأثر العاطفي والنفسي لتأثير العقم على الحالة النفسية. لمزيد من المعلومات اتصلوا على 248-952-9600 248-952-9600.
When it comes to reproductive medicine, IVF Michigan Fertility Centers are the recognized leaders. With locations in Bloomfield Hills and 5 other cities in Michigan and Ohio, IVF has experts in all aspects of the field. As a founding member of IVF Michigan Fertility Centers, Dr. Nicholas Shamma is one of the leading reproductive endocrinologists in Michigan and Ohio. Dr. Shamma has performed over 10,000 IVF cases and has helped thousands of couples fulfill their dreams of parenthood. American board certified in both obstetrics and gynecology and reproductive endocrinology and infertility, Dr. Nicholas Shamma is a very caring, compassionate, expert physician that understands not only the medical but also the emotional toil of infertility.
Welcome back, and thank you for being with us. We're talking to Dr. Shamma about fertility. Dr. Shamma, the last 3 years or two and a half years have been very challenging, with Corona and COVID and it really challenged everyone. First, give us a quick update. Where are we now? We have like a triple demic, they say, or where are we now? And how is it really affecting what you do?
Yeah, I mean, it's actually interesting that you asked that question, Khalil, because those past 2 years, and we're still in it, those past 2 years have been, if I'm going to say demanding on us, is an understatement. I mean, COVID hit us back in March 2020. And I'll tell you, we didn't have any at that time in the United States and in general, and in our field, like all other fields of medicine, we didn't have standard operating procedures in place to know how to deal with a situation like this.
Exactly.
We didn't know. And remember, in the first year, 2020, we didn't have any vaccines till December, actually till January 2021, that we had a vaccine that became available. So we didn't have vaccines. We didn't have any technology to deal with it. We didn't know what we need to do in the lab. And we had all those situations that were almost anxiety provoking to a significant degree. I'll give you an example. We didn't know, for instance, what we need to do to protect ourselves and our laboratory personnel. Remember, I mean, I have PhDs in the lab. I have personnel in the lab. If something happens to them, how are we going to be able to deal with the embryos? How are we going to be able to manage embryos that, if you do not cater to them and treat them with tender love and care, to put it mildly, then they won't develop. Absolutely. And they might die.
Yeah.
And we had issues, for instance, with liquid nitrogen, which is I mean, all our embryos are frozen as if they're frozen on the surface of Saturn. Actually, it's the same temperature, minus 170 degrees Celsius. So we needed liquid nitrogens, and I was worried and almost petrified that at some point in time, the liquid nitrogen tanks are not going to come. So we had to actually put in place technologies to generate our own, for instance, liquid nitrogen on site. Because I was worried that not only that we won't have it, but then the personnel might not have it, or the delivery systems might not be there. So we had to put things
improvise.
Forget to improvise. We had to develop technologies to be able to deal with those situations that were unheard of. And then, I mean, we had we closed shop for almost a month and a half for me to put those SOPs, standard operating procedures, in place so that I can actually have a safe environment for us, for our patients, and for the laboratory personnel, and of course for our biological products, which are in this case all potential life. So I mean, that was a major ordeal. And thank God for vaccines. The sad part about those vaccines is they became politicized to a significant degree. And then women that were trying to get pregnant and men who are trying to make their wives pregnant or their partners pregnant were also bombarded, I should say, with misinformation or disinformation that basically made them worried that maybe they shouldn't take whatever vaccines that are available. And it turned out that COVID is worse for fertility than any conceivable concern related to the vaccines. So we had to deal with that. And still to this day, almost 40% of our patients are not vaccinated.
When you say it's worse, COVID is worse for the treatment than anything else, what are you talking about?
What I'm saying is that women that are pregnant are compromised. That's why, Khalil, they don't inject the baby.
Sure.
So among the risk factors for developing severe COVID is somebody who's older, somebody who's immunocompromised,
that's true.
Somebody who's diabetic, somebody who's hypertensive. The fact that you are pregnant or somebody is pregnant puts them in that same subcategory of concern. And especially if you think about it, that 2/3 of women currently in the United States are either overweight or obese. Add to that, some of them, 6-10% of them, develop pregnancy-induced hypertension. That puts them in a super risk category. And we beg all of them to get vaccinated currently, especially now that there is the two main vaccines, the Moderna and the Pfizer, but there are other vaccines. There's actually the Novavax vaccine that has been developed recently that is a wonderful vaccine, covers mostly any variant, and is a protein-based vaccine. So those people that were concerned about taking a nucleic acid-related vaccine, I would say they have no, in my opinion, no excuse for them not taking a COVID vaccine, especially that the Novavax vaccine is currently available. And I mean, it's available at Costco, not that I have anything to do with Costco. And so, I mean, they can go take it there.
Yeah. The vaccine now, I mean, I've taken my boosters and all of that, and now it covers a wide variety of variants, so we don't have to worry about it.
Yeah, well, I mean, the problem with the vaccines is that they're not long-lasting, at least the RNA ones. So they only last for a few months, and then the variants come in, and then they become not as effective to some degree. So that's why we need to keep up getting vaccinated. It's not that we took one, okay, like a year and a half ago, and we're like protected, because we're not protected, probably.
And today, you know, with the you know, we have the flu, the SRV, then we have the COVID. Has that really affected you, or you have everything in place to take care of your patients?
No, because see, it's interesting. We are still masked in the office, and we still take every precaution in our labs and so on. And that's because we cannot get sick and then nobody can take care of the embryos. I mean, there's so much redundancy in our systems that we are still in a hyper COVID related mode. And I don't know at what point in time we're going to be maskless. So we're still masked in the office and requiring all our patients to be masked in our office. So these things have helped. And the fact that 100% of, let's say, my 170 employees are all vaccinated, all of them, and boosted. So therefore, the chances of having a significant widespread transmission event in our office is minimal, and therefore operations can continue happening and so on.
Yeah, no, for those who are not familiar with the operation, can you briefly tell us what does it take to really create a baby?
Create a baby, I mean, thank God for the heavens, because that's what creates it at the end of the day. We humans play some role in this. So somebody, actually, I'll tell you this, somebody estimated, Khalil, that it takes around 350 steps from A to Z in the process of in vitro fertilization or assisted reproduction. I'm going to sum it up in 5 steps. First, the patient, the woman, takes medicines to make her produce a bunch of eggs. Then we take the eggs out. Then we try to fertilize those eggs one way or the other, creating fertilized eggs or embryos. Then we develop the embryos into some stage where they can be transferred. And finally, the 5th stage is we put the embryos into somebody's uterus. And I'll tell you that one of the things that have recently developed, to the extent that almost 20% of our procedures are related to that, is what we call third-party reproduction, which means in the past, women that ran out of eggs didn't have any options, correct? Now they can use eggs from somebody else, from a third party, from a younger woman. Men who didn't have sperm now can use sperm from somebody else, even though that is, because of technologies that we have, it has really, that number has actually shrunk, even though the number of eggs from third parties have increased, to the extent that 20% of all procedures relate to third-party reproduction. And the third part of that paradigm is that some women that do not have a uterus or lost a uterus or have been unable to carry themselves for one reason or another now use gestational surrogacy as part of the process. So this third-party reproduction, whether it's donor eggs, donor sperm, gestational surrogacy, has become a major part of assisted reproduction. The second thing that, in my opinion, has become really significant in the past year or so, or a couple of years, I should say, is that non-traditional families, Khalil, have become more acceptable. Let's put it this way.
Exactly.
So you have single women trying to have babies. You have same-sex couples, whether men or women or whatever. All of those it became acceptable in our society that those people should and can and are able and do have families of their own. So that's part of the drive that has been going on for years and years to make those procedures acceptable to society in general. That was one. And then making those types of families acceptable by the rest of society that is traditionally, heterosexual in many, many, many ways. So those are important things. The third part of it that I would say that has happened in the past, I would say, few years, is the importance of genetics in what we do for a living. I would say somebody actually, my division head at Yale, who's currently head of the NIH reproductive division, his name is Alan DeCherney. Dr. DeCherney actually suggested that our field, instead of being reproductive endocrinology and infertility, ought to be changed to reproductive genetics and infertility, because currently I would say at least 30% of my work has to do with genetics. And to explain this, in the past,
before you explain that, let's take a short break and we'll be right back.
Sure.
Please stay tuned.
Sure.
On behalf of the U.S. Arab Radio team, we wish our listeners, followers, and community happy holidays, and we'd like to give you a big thanks for your continuous support.
مراكز IVF للخصوبة وأطفال الأنابيب تستقبل مراجعيها في بلومفيلد هيلز ومراكزها المنتشرة في ميشيغان وأوهايو. فريق من أمهر الأخصائيين في مجال التلقيح الاصطناعي. يعتبر دكتور شما أخصائي الأمراض النسائية والتوليد من أمهر استشاريي الأمراض التناسلية والعقم بخبرة أكثر من 10,000 عملية طفل أنبوب. رعاية طبية ممتازة وتفهم عميق للأثر العاطفي والنفسي لتأثير العقم على الحالة النفسية. لمزيد من المعلومات اتصلوا على 248-952-9600 248-952-9600.
When it comes to reproductive medicine, IVF Michigan Fertility Centers are the recognized leaders. With locations in Bloomfield Hills and 5 other cities in Michigan and Ohio, IVF has experts in all aspects of the field. As a founding member of IVF Michigan Fertility Centers, Dr. Nicholas Shamma is one of the leading reproductive endocrinologists in Michigan and Ohio. Dr. Shamma has performed over 10,000 IVF cases and has helped thousands of couples fulfill their dreams of parenthood. American board certified in both obstetrics and gynecology and reproductive endocrinology and infertility, Dr. Nicholas Shamma is a very caring, compassionate, expert physician that understands not only the medical but also the emotional toil of infertility.
Welcome back, and thank you for being with us. This is Khalil Hachem. We're talking to Dr. Shamma. Dr. Shamma, before we went on a break, you were talking about genetics and you know how much it plays a role in what you do. Just want you to pick up where we left.
So as we said, one of the changes that's been happening in our field is that the move or the change into having more genetics being part of what we do for a living. So let me explain that. In the past, we used to put embryos that seem to look good, correct? I mean, they look good in the lab. They're day 5 or day 6 blast. Blast is meaning it's a day 5 embryo. We used to put those and hope for the best. And sometimes we used to put more than one to allow implantation to happen. And then we realized that if you take, for instance, a fertilized eggs, generally speaking, for that egg to become an 8-cell embryo, in the process, somewhere around 30% in good labs of those embryos are lost. And then among those that become day 3, somewhere around, I would say, another maybe 40% are lost. So in total, a lot of them are lost, which ends up with somewhere around maybe 50% of the embryos develop to day 5. But then those embryos, we didn't know that they were genetically normal or not. And we knew that as women age, 2 things happen. Their success rate dramatically go down. And if I want to put that in perspective, if you take, for instance, somebody who is less than 35 compared to 35 to 37, there is a 15% drop in that age group. And from that to 38 to 40, another 15% drop in success rates or live birth rate. And the main reason is that the number of embryos that are genetically normal diminish as women grow older. So we tended in the past to put more embryos to offset for that genetic concern. Now, the problem is that we didn't know which one are genetically normal or not. So nowadays, one of the main issue with genetics helping us is that now we can check the embryos, we can test them genetically before I put them back, and then put only one embryo at the end of the day. And the advantage of this is significant. Let me tell you before I tell you the advantage, I want to tell you that some numbers that are interesting. If you take a 35-year-old, half of her embryos are genetically normal. If you take a woman that is somewhere around 40 years old, only 25% of her embryos are genetically normal. If you take a woman who's 42, only 20% are genetically normal. And they all look similar, those embryos. And I cannot tell. So therefore, I am able, by doing genetics, to pick the genetically normal embryo, increase my pregnancy rate, and at the same time minimize, almost eliminate the possibility of having multiple gestations. And the problem with that is that I don't have to put more than one embryo to get a 76% delivery rate. And that allows the patient to do a lot of things instead of doing multiple cycles and not knowing what's happening with that are financially demanding, emotionally demanding, and also what I call temporally demanding, because then they get older if things don't work out. We can just put one embryo, achieve a very high pregnancy rate, and almost eliminate multiple pregnancy rate. And the problem with multiple pregnancy is, think about it this way. If we have twins compared to singletons, the chances of a baby in a twin pregnancy has almost 10 times more the risks of cerebral palsy and almost 4 times the risk of infant mortality, mainly because of prematurity. And almost 50 to 60% of those twins will deliver prematurely. And we know that equates to lower IQ in those kids that are born prematurely. Think about it this way. Almost the gray matter in our brains increases by 50% in the last month of pregnancy. So if you were born at 36 weeks instead of 40 weeks, that 50%, you don't get it. And 300% increase in the white matter in our brain happens in the last month. Again, if you don't have that, then you're going to end up with a kid with a lower IQ. No question about that. Sure. Regardless of the technology that exists to keep that baby alive and make it grow and so on. So to make a long story short, this genetics allowed us to almost eliminate multiple pregnancy, eliminate the emotional concern related to failed cycles, almost dramatically decrease miscarriage rates. So instead of women in their 40s having 50-75% chance of miscarriage, that goes down to somewhere around 8%. So that's an important factor. Now, the other parts of genetics, and that's why almost a lot of my cases have to do with genetics these days, is that, think about it this way. 6 to 8% of couples, and I want to say something about our Arab community, sure, because of more consanguinity, meaning people marrying people that are related to them, especially in the old country, in the old part of the country. The chances of couples having recessive genetic disorders that they don't show themselves, but can, if both of them have the same gene, can pass it to the next generation, I would say it's probably closer to 10 to 12% in our community rather than 6 to 8%, which is in the Caucasian community. And therefore, in those situations where, if that is the case, a quarter of their kids would have a significant genetic disease, we actually can eliminate those diseases by choosing the embryos that don't have both of those genes in them. And that is, I would say, maybe somewhere around 5-10% of our cases that we're doing today have to do with what we call pre-implantation genetic testing for specifically those types of monogenic disorders, genetic disorders that are related to either the parent and both parents have the same gene, or one of them has a dominant gene that we're trying to prevent in the next generation. So that is a major thing. And lastly, as far as genetics is concerned, Khalil, the other thing has to do with in women that have repetitive implantation failures because of genetic concerns related to the parents, we can actually, again, choose the embryos that don't have what we call translocations or deletions or inversions that one or both of the parents have, and choose the embryos that are free of those disturbances, and therefore allow an implantation to happen and a baby to be completely normal at the end of the day.
Yeah, maybe Dr. Journey is right to change it to genetics.
I'm telling you, he's always been. I mean, he's older now, and yet he's. I mean, God give him longer life even. He moved to the NIH from Yale years. Had a stint in California. But to make a long story short, he's always been visionary in many ways. And so who knows if they're going to change the name of our field? But
how long is the duration for the treatment?
The treatment actually depends. There are so many subtypes of the treatment. What I mentioned to you in terms of those 5 steps out of the 350 has to do with the standard IVF. It's not when we generate embryos in one place, put them in another place, or using eggs or sperm or whatever from other sources. But generally speaking, a standard IVF cycle is simply around 14 days to generate the embryos. We take the egg to have those embryos. We have to take the eggs first, and that's a 6-minute procedure that happens in the laboratory and in the operating room. And then we take those eggs, we microsurgically fertilize them a lot of times by injecting the sperm inside the egg. And then the patient, doesn't have to do anything. So those embryos are developed into day 5 or days embryos or so, and then either a fresh embryo is put into the uterus. So we're talking about 14 days plus 5 days, around 19 days. And the way you put the embryo back is a very simple procedure done in the operating room, but takes around 5 minutes. The other one takes around, at least in good hands, 6 minutes or so. And literally that is it. Now, if the embryos are frozen because we need to do genetic testing on them, because we do the genetic testing by taking few cells out of each, and then they're all frozen. It takes us 10 days or so to get the results. So all of those embryos are frozen. That's why I shared with you that almost 85% of all babies born in the United States are because of thawed embryos that have been initially frozen. So those embryos are frozen, and then some 4.5 weeks later, we'll put that embryo back in that patient, generally speaking. And again, putting the embryo back is easy. It's easy in good hands, let's put it that way. Because some people ask me a lot of times, why do some people have higher chances of making patients pregnant than other? See, I always tell them that success rates in our field depends on 3 factors. And the first factor has to do with the patient themselves. Because, if you are 50 years of age, it's not going to work, right? Because the eggs are all genetically abnormal, or you ran out of it. But it depends on the eggs, depends on their genetics, depends on the age of the patient, depends on the medical condition that the patient and their husband bring to the table. But then the lab is very important. If you have a very nice patient, but a lab that cannot deliver the product that you want, which is basically, in this case, potential life, the embryo, then nothing happens, correct? Now, you also have to have a good uterus at the end of the day. You have to have a uterus that is able to sustain a pregnancy.
Yeah.
And you have to make it receptive. It's not always receptive. You have to make it receptive. So you have to have, the doctor has to have the know-how to be able to do that also, in addition to creating help generate the eggs in the first place. But then the third factor is probably maybe the most important of all of them, and that's the one that is hard to teach, and that has to do with experience and skill. Because you could have the best embryo on planet Earth and the best uterus. If the doctor doesn't know how to put that embryo safely into the uterine environment, into the uterus, nothing happens, correct? I mean, it's not, I can raise a baby 9 months in the laboratory and then hope for the best. That doesn't happen yet.
It doesn't work that way, yeah.
Yeah, it doesn't, not yet, I should say, but it's not going to happen anytime.
Yeah.
So that factor is very important.
Absolutely. What we're going to do is we're going to take a short break. Please stay tuned.
On behalf of the U.S. Arab Radio team, we wish our listeners, followers, and community happy holidays, and we'd like to give you a big thanks for your continuous support. When it comes to reproductive medicine, IVF Michigan Fertility Centers are the recognized leaders. With locations in Bloomfield Hills and 5 other cities in Michigan and Ohio, IVF has experts in all aspects of the field. As a founding member of IVF Michigan Fertility Centers, Dr. Nicholas Shamma is one of the leading reproductive endocrinologists in Michigan and Ohio. Dr. Shamma has performed over 10,000 IVF cases and has helped thousands of couples fulfill their dreams of parenthood. American board certified in both obstetrics and gynecology and reproductive endocrinology and infertility, Dr. Nicholas Shamma is a very caring, compassionate, expert physician that understands not only the medical but also the emotional toil of infertility.
مراكز IVF للخصوبة وأطفال الأنابيب تستقبل مراجعيها في بلومفيلد هيلز ومراكزها المنتشرة في ميشيغان وأوهايو. فريق من أمهر الأخصائيين في مجال التلقيح الاصطناعي. يعتبر دكتور شما أخصائي الأمراض النسائية والتوليد من أمهر استشاريي الأمراض التناسلية والعقم بخبرة أكثر من 10,000 عملية طفل أنبوب. رعاية طبية ممتازة وتفهم عميق للأثر العاطفي والنفسي لتأثير العقم على الحالة النفسية. لمزيد من المعلومات اتصلوا على 248-952-9600 248-952-9600.
Welcome back and thank you for being with us. We're talking to Dr. Shamma about infertility. Does the age of the father play a role?
Yeah, I mean, me being a man, I would say no, just joking. But we do play a major role. But generally speaking, not in the same way as eggs. Women are, unfortunately, because of many reasons, because of more education nowadays, because of better career opportunities, are delaying childbearing. Actually, in the Western world currently, the age for the first baby is somewhere around 30, if not older. Whereas the major fecundity rate, the major odds of delivering a kid is in the mid-20s. So for women, as they age, 2 things happen. The number of eggs that they have diminish, Khalil, and the number of embryos generated from those eggs therefore diminish, and the quality of those eggs diminish. So basically, they have less eggs, and the quality is less. Just to put this in perspective before we talk about men, if you take a woman that is 30, she has probably left over somewhere around maybe 50 to 100,000 eggs. If you take a woman that is 37 years of age, she might have somewhere around 25,000 eggs left. And if she's 40, only 10,000 eggs left. And more importantly, out of those 10,000 eggs left at 40, 75% of them are not genetically normal. So that is why fecundity, which is the chance of delivering a healthy child, diminish as one gets older, and the rate of chromosomal abnormality, genetic abnormalities, increase with women as they get older. For us men, there is a trend, but nothing significant before the age maybe 40 to 50. And even then, it is not significant. I mean, in many ways. So yes, genetic plays a role to some degree in men in terms of having more DNA breaks and so on. And DNA is the genetic material that we have, but not even close to what women have going older. We know that some men, even in their 70s, can father children.
Yes, true. Yeah. My neighbor was 75 in the old country, and he got married and fathered a child, and now he's a genius.
Well, I mean, it does happen. I mean,
yeah. In the case of a surrogate, if you take an embryo and put it in a surrogate, the DNA, the what really shapes that child, is it the environment that's in, or is it that embryo and then the sperm that played a role in it?
Well, I mean, I think it's both.
Okay.
But to a significant degree, it's the embryo itself. I mean, I should say something. I think gestational surrogacy is the most beautiful gift any human can give to any other human, actually. And that's why I think
the gift of life.
It's called the gift of life. I mean, that's actually why I called my agency in Ohio the Gift of Life Surrogacy Agency. And the reason I said we did it in Ohio as opposed to in Michigan, not that I don't like Ohio, I mean, I love Ohio, is because Michigan is the only state in the union that criminalizes gestational surrogacy. It's actually criminal to do it in the state of Michigan. So that's why we opened the agency in the state of Ohio, and then that's fine. But I called it the Gift of Life Surrogacy Agency. So having said that, and knowing how special those women are, the gestation carriers that are doing this to help other people, carry a pregnancy and having a child where they are incapable of having a child, the genetic material of the baby is what determines how the baby is going to look like, how the baby is going to be, tall, short, smart, not smart, whatever. All of those are determined by genetics of the parents that provided the egg and the sperm.
Okay.
The gestational carrier's environment is also important because that's what we call epigenetics, in the sense that, I mean, we choose those gestational carriers very carefully in the sense that they have good diets, because that's basically what the baby needs a uterus that is able to supply adequate oxygen to it, adequate blood flow to it, adequate nutrition to it, and then the baby commandeers that uterus for 9 months. So I would say there is less genetic contribution, if any, from the gestational carrier to the baby, but clearly you need a suitable environment. You can't put that embryo in a place where it is surrounded by, let's say, a situation where the gestational carrier smokes or drinks or does horrible things and so on, and that baby then is not going to do well, put it in mind.
Sure.
Regardless of genetics.
Yeah. Now, here's if you mentioned something about the state of Michigan and the legalities, and now we have a lot of states are changing a lot of laws, and when it comes surrounding abortion, which really has nothing to do with you, but they're imposing different laws. Would that affect what you guys do, or this is something that really has nothing to do with you?
Well, I mean, you're talking to somebody I have never. I mean, I don't do abortions. I don't do anything related to termination of life. I do the other part of the spectrum. But having said that, I respect women who potentially want to have that as an option for them. With that being said, I know that the state of Michigan we had a proposal 3 on the ballot, and proposal 3 now basically codified the fact that that law that was passed in 1931, Khalil, is no longer valid, and abortion is legal in the state of Michigan, I guess, in perpetuity until something changes. So at least in the state of Michigan, we're good. And as far as the anti-abortion sentiment, on the contrary, the abortion law that we had in place is no longer valid, and that's the end of the story, I think, in the state of Michigan. Now, the state of Ohio is a little bit different. just to talk about other states, is different because they did the reverse over there type of thing, and then they might make it more difficult for women to have abortions. But then two things as far as our field that could be affected by this. One is if they consider life as starting upon fertilization, and therefore what are you going to do with the embryos that don't look good and die? I mean,
Exactly.
And what do you do about the frozen embryos that are not genetically normal and so on? Now, it's not going to affect us in any way, at least for us at IVF Michigan, IVF Ohio, because all of our procedures are done in the state of Michigan, not in the state of Ohio. It just happened.
Okay. Yeah, exactly. So, and this is why I asked that question, because
so it has zero effect on us. But I think that, I mean, it's going to be very hard for the people in the state congresses and the state legislators to prevent those 1 million babies that would have existed in the United States, prevent them from existing in the first place. And think about it this way. For every 1,000 women, for our population not to shrink, you need 2,100 babies. We don't have that in the United States.
Yeah.
And in the Western world. And especially with COVID now, things have even deteriorated where the birth rate has actually decreased. So therefore, imagine if 2% of all babies born are prevented from being born if they eliminate the technologies. Those 1 million babies I told you about would not have happened. Yeah. And so for me, I'm all for helping create life and making women and men and couples and everybody happy. It'll be very hard for me to imagine that somebody in any state legislatures will come up with some law that curtails or inhibits or restricts the access to fertility services, to IVF and so on.
Yeah. Has there been any, in the past year, has there been any new technology? And I mean, you talked a little bit about genetics or any breakthrough in what you do that helped you, and what's the future holds?
Well, I think the technology, the genetics is going to continue developing, and it's actually going to open Pandora's box in the next few years in relation to what we call polygenic disorders that are not really black and white, where you're either sick and we're preventing it and not sick and therefore allowing you to develop. But we're talking about like the ability for us to choose embryos that would turn out to be, intellectually more advanced than other. So, we might find out what are the genes involved in having a kid that succeeds in sports or has a high IQ and so on. And then can we do that, or should we do that? That's a debatable ethical Pandora's box, I think. The other thing has to do with technology itself, and that's basically everything is becoming miniaturized. So let me start with that. And there is a push in our field of having what we call a laboratory on a chip, meaning it's something called microfluidics. Microfluidics is a science that miniaturizes the fluid environment within which early embryos develop and sperm can be sorted and so on. And we're moving from big incubators to smaller incubators to even now microchips, allowing those embryos to develop in. And that changes the geometry of the environment within which that embryo lives and allows that embryo to be able to live by itself in those very controlled environments without humans playing a major role. So that is a major advancement that's going to happen in the next 5 to 10 years. That's going to sort of dramatically change the way we do things in the laboratory. And then there's technologies involving freezing of the embryos and so on, and technologies that we do that's also going to continue to being developed in the next few years. So all of those are things that we can see in the horizon, whether it's genetics, whether it's microfluidics, or whether it's cryopreservation technologies and so on, all of those are going to continue to develop.
Absolutely. As far as accomplishments in the past year, what are you so proud of? Anything to point out?
Well, actually, I don't want to use the word proud of. I'm proud of everybody in my office. I'm proud of my nurses. I'm proud of my biologists. I'm proud of my ancillary staff that helps us do things and so on. But I'm actually more than proud. I'm grateful.
Exactly.
I'm grateful that we were able, despite this horrible pandemic or whatever tri-pandemics with coming up with the RSV and with the influenza and so on, that we're able to continue offering those services for patients. Because remember something, I cannot stop time. I cannot stop women from becoming older, correct?
Sure.
And that is something we cannot just say stop and we'll see you in 2 years, because in 2 years it will be too late sometimes to a lot of patients.
Yeah. Yeah.
So I am thankful that whatever it is we put in place to allow us to continue and pursue and offer those services to our patients have allowed us to continue in our success. And I'm actually literally more grateful than and thankful than proud.
Absolutely. Is there anything I haven't asked you that people need to know?
I mean, it's a 30-year experience in science and practice. There's a lot of things you didn't ask me, and we can leave those for other times and whatnot.
Sure.
But I think I want to take maybe a few seconds to tell everyone a very happy holiday season, and may God make 2023 a beautiful year where if they have dreams, for that dreams to happen, and if they have fears, for those fears to dissipate. And God bless all of them.
Absolutely. I want to thank you so much for taking the time to be with us. It has always a pleasure. I do, ever since I start talking to you, I pay a lot of attention to IVF, and when it's in the news, I read about it, and I read about it sometimes, and I learned a lot from you. And this is it's really a magical field. I just can't imagine the joy when people come to you and then they end up going home with a baby. I mean, it's not. I don't want to make it sound like shopping, but it's when things work to their advantage.
And thank God it does a lot of times. So on that note, best holiday season in the world, and may God bless all our patients and all of you.
Absolutely. Happy holidays to you and your family. Thank you so much.
Bye.
We appreciate it. Thank you.
Bye.
Bye now.